Okay, maybe in view of time we can continue with the allogeneic presentation from Dr. Paul Weiss, who is also from Great Ormond Street, who is a very well-known, widely known transplanter in pediatric immune disorders for many, many years. Paul, we can see the first slide. The floor is yours.
Okay, I'm just going to get the presentation up on my end as well.
Paul, Juliana is on now.
Oh, is she?
Okay.
Yeah, I hope she can hear. I've just asked.
Yes, I can hear.
Hi.
Hi, Juliana.
Hi, Paul.
So, yes.
You're going to sing together or what?
We'll try. So, that's perfect timing. So, good morning, I think, everybody there. I'm just going to talk about allogeneic transplant for JIA, and obviously this is a very rare event. And Juliana has done a fantastic job in getting 12 patients together, and they're from all around the world, from 5 centres. I think you've obviously got Nico in the audience. I think you've got Rebecca Marsh in the audience as well.
Yep. Yes.
Okay, so very quickly, therapeutic options, transplant, whether it is autologous or allogeneic, comes very much down the bottom of the hierarchy, and that has been a very difficult and important question for us, is whether we should be thinking about autologous transplants before we think about allogeneic transplants. And just lately, rightly or wrongly, we've decided to go, if transplant is required in a child, we decided to go straight for an allogeneic procedure, and I'll try and explain why. So potential advantages of going straight to an allogeneic transplant. We know in other autoimmune diseases, I agree that JIA may be more autoinflammatory, but in other autoimmune diseases, which we do for gut and indeed severe cytopenias, we know that an allogeneic transplant does provide very significant graft versus autoimmunity. So it is the most powerful weapon to turn autoimmunity off. And you were listening to the discussions by Nico and Lucy.
So Paul, sorry, but if you change the slides, can you say the number of the slide that you're on?
Right, I'm on number 6.
6, yeah.
You got that one?
Yeah, we're looking at it.
Yeah.
Okay, sorry, I'll call those out.
Yes.
You heard what Nico and Lucy were saying about these T-cell clones. Well, in the allogeneic transplant, if you have 100% lymphoid chimerism, T cells and B cells, actually those clones have gone. So they're no longer in question. If you have a mixed chimera, they could still be there. And then perhaps the most important reason for us changing was that you can actually deliver stronger immune suppression, yet get quick immune reconstitution. So you can't really do that in the autologous setting, because if you remove all recipient T cells and B cells beforehand, and then you remove everything from the graft, you're going to have a very immunocompromised child for many months, perhaps up to 6 months, and that's a real risk for infection. So this was the major reason, having had some children die from infection shortly after autografts. This was the reason we went to the allogeneic procedure. Risks, again, will be obvious. So allogeneic transplant is associated with increased transplant-related morbidity and mortality, and particularly compared to autologous transplant, GVHD. So I'm on slide 7.
Yeah.
So what Juliana managed to gather was data on 12 patients retrospectively, 5 from Gosh, 2 from UCL, 2 from Newcastle, 1 from Prague, and 2 from Rebecca in Cincinnati, over an 8-year study period going back to 2007. And we were looking at the outcomes of survival without disease, and then, very importantly, mortality associated with procedure and the occurrence of GVHD. So indications for allogeneic transplant: 7 out of 12 had refractory disease, 1 following an autologous procedure, which is the patient Lucy just mentioned. 4 were transplanted because they presented with macrophage activation syndrome. 1 of the 12 had refractory disease associated with a primary immune deficiency of unknown genetic cause. I'm on slide 9 now. So this slide is just, in fact, the next 2 slides just give the details of the patients. The first column is the year of transplant. The second column is the age of transplant. Third column is type of disease at onset. And fourth column, age at onset. And then the treatment column. And just a couple of things to note. You'll notice the difference between the age of transplant and the age of onset is quite large. The bottom and next to bottom, you'll see there's almost 15 years between onset of disease and an allogeneic transplant. The period is shorter in some of the others. And then the other thing that you'll see in the treatments is a large array of treatments, including nearly all the MABs available to us, have been used in some of the patients. And if I just go on to the next slide, you'll see the remaining patients there. Slightly less gap between onset and transplant. But again, these children had failed a whole plethora of biological modifying agents. So unlike most transplant approaches, this was fairly homogeneous. 9 out of the 12 children had what we call a reduced intensity procedure with fludarabine, melphalan, and alemtuzumab, that's Campath. And 3 had what we call a reduced toxicity regime, which is the fludarabine triasulfan, which is like a busulfan analog, and again, alemtuzumab. So fairly homogeneous, and GVHD prophylaxis largely cyclosporin and MMF. I'm on slide 12. Not all patients received matched donors. There were 9 patients who received matched donors. 7 of these were unrelated donors, 2 were siblings. And 3 children actually received one antigen mismatched donor, either at the C or DQ locus. 11 out of 12 had peripheral blood rather than bone marrow as a stem cell source. And those are the sort of stem cell doses for transplanters, really. So quite a high dose of CD34s, 10. And that's the median T cell dose there at 3 times 10 to the 8. Now, how did these children do? So this is slide 13. So if we go down the left-hand side first, so 11 patients achieved donor myeloid and lymphoid engraftment. There was 1 child who only ever had partial T-cell engraftment, and very interestingly, but the follow-up is reasonably short, is well without disease. So that does ask some questions. Of those that got myeloid and lymphoid engraftment, 9 of those are well and free of disease and off all drugs. 2 children, which we'll mention a little bit later, are okay, but they might have had what we call a partial remission, so they've had some problems from arthritis after the graft. And sadly, one child that Lucy mentioned died following surgery, having been well at the time, and we don't really know what happened. She was under an orthopedic team, but it may have been sepsis following an orthopedic procedure to her knee. This is the one that had a previous failed autologous transplant about 18 months prior, I think.
Yeah.
Those are the cell recoveries, so fairly quick count recoveries down at the bottom there. So this is a slide we might hope give us some answers. So this is now looking at chimerism in each of the patients, and there's the remaining 4 patients are on the second slide. So the circle reflects donor myeloid engraftment. Sorry, the circle reflects myeloid engraftment. The squares reflect T-cell engraftment, and the colours really depend on whether it's donor for green, red is all recipients, and the orange is a mixed chimera. So we were hoping to be able to learn some things from this, but I'm not sure there are any immediate answers. Patients that may be of significant interest are patient 7. So this is one of the children that we've described as partial remission. And you note, in fact, this child was a mixed chimera in both lineages, and actually quite a large amount of recipient clones in the T-cell lineage. So it is possible some of those clones Lucy were talking about are still there. However, there are other patients, like the bottom one, where there was only T-cell engraftment and low level, and yet no return of disease as yet. So it's not as simple as if you get 100% engraftment across the board, you will necessarily be disease-free. And the other way round, even with some donor engraftment, you might remain disease-free, but this might change with time. If we just go to the last few patients, just to illustrate what I've said, so here's another child, the second child in partial remission, and yet this child is a full donor chimera in both the myeloid lineage and the T-cell lineage. So it's not clear why some children may not be completely responding, and I think we need further follow-up. Okay, so slide 16, problems with transplant. Anybody that uses alemtuzumab will know the major problem is in fact viruses. So in all these various patients, you'll see everything in red is a virus infection. Not easy to treat, but possible to treat. And the secret with using alemtuzumab, which I think is important for the success, is monitoring these viruses very closely. And these are reactivating viruses. So CMV, EBV, adenovirus, they're not acquired infections. They're already in the cells, already in the DNA, and they just reactivate during immune suppression. So they need to be watched for. But the good side to alemtuzumab is that very little graft versus host disease, which is obviously one of the big problems when you're talking about allogeneic transplantation. So no significant chronic GVHD, and just 1 out of 12 with significant acute GVHD, which was treatable. Immune recovery, well, actually, this is quite slow. And I think this both reflects alemtuzumab use and also probably these patients starting off with quite poor immune systems because of all the steroids, methotrexate, and biological modifiers. So I think that combination leads to quite a slow immune reconstitution, really taking 12 months or so before the levels reach sort of normality. And again, this is another reason, or this is the main reason why they do get viral infections in the post-transplant period. How did they do? Well, actually quite well from the disease point of view. So here's a bar diagram showing active joints pre-transplant and at last follow-up. So there were 2 children that had been classified as PR. One had a brief reactivation of arthritis requiring steroids, which is now stopped and the disease is gone. And one child is still on, and in fact is the only child on immune suppression, is still on 0.5 milligrams per kilo of prednisolone to keep their disease under control.
And Paul, what's the median follow-up time?
18 months. 18 months.
18 months, there you go. Thank you, Juliana.
Okay.
So that may still be quite short.
But some fairly long, Juliana, right?
Yeah.
That's right. Some of them are like 4 years, 72 months.
Yeah. So a range, yeah.
Yeah.
Okay, and then there's the inflammatory.
In the autologous series, Paul, is that there were 3 cases out of 36 or something who had very late relapse of the disease, initiated possibly by an infection. Did you come across this already or not at all in the allogeneic series?
There was one child that reactivated and then responded to steroids and is now off. That might have been started by infection. We're not sure. May have been a viral infection, but not a definite. That's not a definite pathway in the allogeneic setting.
Okay.
But yes, it's small numbers of patients, and we need further follow-up. So if you just click on to the next one, which is 20, again, inflammatory parameters have normalized in the majority of patients, apart from those 2 that we were mentioning. And very importantly, I think for the long term, is actually 11 of the 12 patients are completely off immunosuppressive medication.
Amazing.
Which I think is extremely important for the long term, because we talk about long-term side effects of transplant, but I would argue the long-term side effects of the reduced intensity conditioning will be far less than if these children had continued on drugs. But we could argue that either way. So let me just see, I think, those are the conclusions, that's slide 22. So what we're suggesting is that allogeneic graft using alemtuzumab, I think, which might be quite important, plus reduced intensity conditioning is promising. In a small number of patients, we've had low mortality and morbidity, but lots of viral infections which have to be watched for. Timing of transplant might be important. So one of those children that reactivated and is back on immune suppression had terrible disease going in with poor control. So maybe in that child, we waited far too long to do this. The next point I've made already, and of course, this is a small number of patients, and the only way forward to really know how good this is would be to study it in a prospective manner, trying to harmonize all these sort of inclusion criteria and obviously exclusions. So thank you to all the people that send data and Juliana for gathering this. I'm hoping Juliana is going to try and put this together in a paper now. I think it's promising data. but we need more time and more patients to know just how good it is. Thank you.